Hello everyone, it's me Dr. Ayaz Ahmed, working as an aesthetic dermatologist. So last time I discussed about management of atopic dermatitis and covered first line management. Today I will cover second line management of atopic dermatitis. So second line management includes topical calcineurin inhibitors. Topical calcineurin inhibitors include tacrolimus and pimacrolimus. Tacrolimus 0.1 percentage in adult and in children 0.03 percentage over 2 years with moderate to severe atopic dermatitis, which is usually not controlled by the steroids are used. Pimacrolimus for corticosteroid resistant cases in a children between 2 to 16 year of age, especially in facial dermatitis. Tacrolimus is an important for resistance eczema in periauricular area, skin thickening and for maintenance therapy. Always note here that whenever steroids are used in periauricular area by a atopic patient, he or she will develop glaucoma in eyes, which is very catastrophic. So we usually prefer tacrolimus in case of periauricular eczema. Allergy management. So most of atopic patient they have constant complaint of allergy, so we will go for its management. About 30 to 40 percentage of cases of atopic eczema are due to food as seen by the specialist. Food allergy may be considered in a patient having immediate reaction to food or GI motility. Breastfeed for at least 3 months prevent from atopic eczema. Some aeroallergen, especially house dust mite, is most important cause of atopic dermatitis that must be avoided. Repeated exposure to allergen may produce desensitization. Contact allergy and phototherapy. Avoid food that cause contact allergy. Here we usually recommend patch testing. Patch testing is usually recommended after settlement of atopic eczema. Broadband UVB, narrowband UVB, medium and high dose UVA1, solar and ultraviolet A radiations are used for phototherapy for the management of atopic eczema. Narrowband therapy is preferred option for chronic disease. Disease activity is reduced to 30 to 50 percentage in 24 course of phototherapy. Unresponsive disease, intensive topical cream and wet trap techniques. So those patients who are not responding to treatment, we must search its adherence or we must search for missing triggering factors. So common cause is adherence, for example steroid phobia. Some people usually believe that steroids may uh, damage their skin or may create some swelling in face and its body. So steroid phobia will lead to adherence and person will not go for steroid as a therapy. So we usually search common adherence here in this case of steroid phobia. Another important factor is the lack of missing or triggering factors. We should search for triggering factors. Increase potency of steroid for a short period to control eczema. If eczema is controlled, then the patient will respond to the same treatment which was previously not responding. So we will first increase potency of steroid. If flare is controlled, then we will go for the same potency of steroid. Another important is wet wrap techniques. In this technique, we use two layers of absorbent bandages that are applied to the skin. Outer layer is dry and inner layer is pre-soaked in a warm water. Very low potency of steroid are applied before dressing and then left it for night and or change it totally overly. Third line management. Third line management includes cyclosporin. It is highly effective in children and adults. Dose is 2.5 to 3 mg per kg per day. Maximum daily dose is 5 mg per kg. Response usually come in 6 to 8 weeks. Cyclosporin is licensed for 8-week course in UK. Renal function and blood pressure monitoring is needed. Azathioprine. Control moderate to severe atopic dermatitis, prescribed as a first-line management in atopic eczema in a child in Europe. Dose adjustment is based on TMPT metabolic enzyme activity in RBC. This enzyme is very important. For suppose if a person having no TMPT enzyme, he or she may not use erythroprime. If a person have very low TMPT enzyme, then dose must be very low. The UL dose is 1 to 3 mg per kg. Those who have low metabolic activity must receive low dose, that is 0.5 to 1 kg, 0.5 to 1 milligram per kg. Regular blood monitoring is needed. Drug interaction with allopurinol and 6-mercaptopurine have been noted. Side effect is neutropenia. Methotrexate. Start methotrexate 10 mg per week after 5 mg test dose. If test dose is okay, then go for 10 mg per week. Then gradually increase it, that is increase 2.5 mg weekly up to maximum 25 mg per week. Time to maximum effect is 10 weeks. It is better tolerated as compared to erythroprime. Mycophenolate mofetil. It is fourth line agent. For example, if cyclosporin or erythroprime is not working or not responding, then we will go for fourth line agent, that is mycophenolate mofetil. Its dose is up to 2 mg per day. Enteric coated 1.5 gram daily is as efficacious as cyclosporin 3 mg per kg as a maintenance therapy for up to 30 weeks. Side effects are GI disturbance, leukopenia, lymphopenia, anemia, and hepatic infection. Biological therapy. Rituximab following 2 infusion of 1000 mg 2 weeks apart are effective. Rapid and dose-dependent improvement with dupilumab were observed. Moreover, no improvement with anti-TNF alpha therapy were observed. Thank you very much. Stay connected and subscribe my YouTube channel.